Hello, my name is Kim Eagle, and I'm from Ann Arbor, Michigan. And I'm here covering the American Heart Association in Philadelphia on this first day of coverage, November 11th. Happy Veterans Day. And we're delighted today to be joined by three outstanding experts in clinical trials: Ajay Kirtane from New York City, Payal Kohli from Denver, and Dharam Kumbhani from Dallas, Texas. We're going to talk today about three trials that are very important. And let's start with maybe the most important trial here called SELECT. Payal, take us away.
Thank you, Kim. Of course, this is a landmark trial, and I'm so excited to be summarizing it. Everyone at the American Heart Association has literally been waiting with bated breath to see the results of this trial. Now, if we recall, we know that GLP-1 receptor agonists, including semaglutide, which was studied in this particular trial, have shown benefit for cardiovascular outcomes in patients with diabetes. What this trial really pushed the envelope with was the question of whether obese patients with cardiovascular disease who don't have diabetes would have MACE benefit with these agents. And the top-line results were announced in August. It was a 20% reduction in the 3-point MACE of cardiovascular death, MI, and stroke. But this was a little bit of a deeper dive. So about 17,000 patients with BMIs equal to or greater than 27 who had pre-existing cardiovascular disease. And this meant clinical cardiovascular disease, either MI, stroke, or symptomatic PAD. And they were up-titrated on semaglutide up to the target dose of 2.4 milligrams, with that titration occurring every month, or matching placebo, actually a sham up-titration as well. And what we saw was that the patients in this trial had about a BMI of 33, an LDL at admission of 78, which some might argue is maybe not good enough for patients who have ASCVD, and about 88% on statins. Again, potentially more people should have been on statins in this trial. But what was really remarkable to me, Kim, was that those curves, they separated almost immediately for that 3-point MACE. And if you looked across the subgroups, the effects were very consistent. And if you looked across the different endpoints, the individual endpoints, they all seemed directionally consistent. Now, the ones that hit statistical significance were MI and notably all-cause death. So there was a 19% reduction in all-cause mortality, with that separation occurring at about 4 to 5 months. Cardiovascular death was kind of on the border of statistically significant, but we also saw a decrease in high-sensitivity CRP of about 38%. Now, the weight loss in this trial, I was a little less impressed by with semaglutide compared to prior trials. It was about 8.5% placebo-corrected reduction in weight. But overall, these results to me have really been game-changing when it comes to how we think about obesity medicine. And the GLP-1 receptor agonists, which have now got a growing list of indications, it seems, have now become a cardiovascular prevention drug. They're no longer just a diabetes drug. They're no longer just a weight loss drug, but actually a cardiovascular prevention drug. So the first demonstration of an intervention in obesity to have MACE benefit. We're not entirely sure if the mechanism is all through weight loss or some of it could be independent of weight loss. Certainly seeing that inflammatory marker go down so much, we know that obesity, increases inflammation, and that could be part of the mechanism. But I am so excited to see the payers come on board with this drug, hopefully after this trial, and start to see a shift in how we're using it. I'm also really excited, waiting for the data from the FLOW trial, which is looking at semaglutide and renal outcomes. We know the top-line results of that trial that'll be presented next year in 2024 are positive as well with respect to renal outcomes.
Thank you, Payal. Great summary, really important trial. I really like what you said. These are cardiovascular agents now. These are not in the realm of diabetes. They're right in our lab, and we need to get comfortable with prescribing them and following patients who are on them. Another trial being released today is called DAPA-MI. Dharam, tell us about that trial.
Yeah, hi, thank you. So, along with the GLP-1 receptor agonist that we just heard about, another drug class that has sort of really taken the cardiovascular world by storm are the SGLT2 inhibitors. And so this is the DAPA-MI trial, which was a registry-based randomized control trial that was done out of the SWEDEHEART registry and the LINEAP registries from Sweden and the UK, respectively. And what the investigators were looking to assess is whether if you added dapagliflozin to patients who presented with an acute MI, but did not have a known history of diabetes or chronic heart failure, if they would have positive cardiometabolic and CV outcomes with this intervention. And so this was a very large study. They randomized 4,000 patients that were followed for about 24 months. And they included patients with both STEMI, predominantly about 72%, as well as non-STEMI. A number of these patients also had an acute drop in LV function, defined as less than 50%. Now, the study design was in the form of a win ratio, which we are seeing increasingly in these large trials. And so the win ratio included a hierarchical composite of death, heart failure hospitalization, myocardial infarction, AFib, type 2 diabetes, NYHA class, as well as a weight decrease of at least 5%. And there were more wins in favor of DAPA compared with placebo in the primary endpoint analysis. And even when they dropped the weight change, it was still in favor of DAPA. Now, when they looked at the MACE endpoints and other cardiovascular benefits, those interestingly were all negative and seemingly similar between the two interventions. The biggest differences were in the diagnosis, a new diagnosis of type 2 diabetes, which was lower with DAPA, as well as a change in body weight of about 1.65 pounds over 2 years of follow-up. And so what this trial suggests that if you added dapagliflozin to usual care for patients who present with an acute MI, there were some important cardiometabolic effects over 2 years of follow-up. This did not translate, at least over this duration, into CV benefit, but the results are definitely interesting. So, compared with the trial we just discussed, I think maybe we would need to discuss whether these observed benefits in the cardiometabolic on the cardiometabolic side, whether those would sort of mean that we would be adding DAPA to all these patients who would not otherwise have an indication compared with sort of usual care. So again, I think, very interesting trial, and I'm sure we'll hear more about this in the days to come.
Thank you for your summary. I tend to agree with you. There were a few wins in the trial, but in terms of the kind of hard endpoints that we just heard about, this probably isn't a game changer. Now, maybe with longer follow-up, we would see that, and so we will await further studies that would be similar to this one. I love the way cardiologists name trials, don't you? And the next one's called Orbita-2. Ajay, tell us about this trial.
Well, speaking of wins, I think that this was one that was a long time coming. I think that it's a very interesting reflection on our field that we didn't really have sham-controlled trials on the effectiveness of PCI versus medical therapy within the field for quite some time until the first orbital trial came out. And when that trial came out a few years ago, it was accompanied by editorials and newspaper articles and a lot of consternation because in that first trial, the effectiveness of PCI compared to medical therapy in a sham was actually not that significant. In a subsequent follow-on publication, there were signals suggesting that PCI was beneficial, but the top-line results of Orbita, the first trial of just over 200 patients, was that the differences were not that great with respect to sham. So credit the Orbita investigators and Raja Alame in particular for designing a follow-on study, really trying to resolve this question once and for all. Because I think concurrent with that initial publication, there was a lot of Twitter trolling and social media saying, well, PCI doesn't really do anything. And I think that went against clinical practice observations by many experienced clinicians, but certainly caused one to question, should we be pushing PCI for patients and maybe we should start medical therapy first? So the question of whether PCI reduced symptoms relative to medical therapy was one that was important to resolve. And I think this trial clearly demonstrates it. The investigators randomized about 300 patients in the UK. These are patients that had had angina for about 8 months in duration. They took them off medications. And the reason they took them off medications is to isolate the effect of PCI versus a sham comparator. And when they did so, enrolling patients that actually had abnormal physiology, they clearly showed there were reductions in angina as measured by a scale integrating both angina symptoms as well as medication burden. And so that was improved. Seattle Angina Questionnaire was improved. Exercise time went up by about 60 seconds as a whole. And overall, I think these results are quite reassuring that the patients that we take that have significant symptoms can benefit from a strategy of PCI. The unblinded effect is probably even greater because patients certainly have the power of suggestion. And it's also, though, important to remember that a fair number of patients still do have residual symptoms. So we have to, above everything else, be good clinicians, assessing our patients. What are their symptoms? Are they attributable to the stenosis? But if we treat them appropriately, we'll be able to reduce their symptoms, and that's reassuring.
Thank you, Ajay. I think it's stunning that it took until 2023 for us to sort of unequivocally prove to ourselves that there are patients going to benefit from PCI for angina. And I thought the investigators were incredibly brave to taper off medications in patients with stable angina. That might have been difficult to do in this country where the medical legal aspects of that might be questionable. But certainly an important trial was a benchmark study in interventional cardiology, and you covered it absolutely beautifully. So there you have it from the first day of the American Heart Meeting. We covered 3 important trials: SELECT, DAPA-MI, and then ORBITA-2. There are other really important trials coming out today, and look for those covered on acc.org. We love bringing you these trials this way. This is Kim Eagle, and for our colleagues, I want to tell you, have a great day, and for acc.org, we're out.